and tobramycin are since then have been shown to have very similar results. So in our clinic, what we have been doing is talking to families about both options and then having the family help us decide which antibiotic to proceed with eradication with. So, even back in 2014, they said other antibiotic therapies may be effective, and they did quite a few combinations. They did tobramycin plus ciprofloxacin, tobramycin by itself, tobramycin IV. They did quite a few different scenarios, and it ends up that tobramycin inhaled by itself for 4 weeks was equal to tobramycin IV for 2 weeks. So why go into the hospital and start IVs whenever you could do get the same outcome at home? So let's look at the next video. Maybe I could play it.
We attempted Pseudomonas eradication with Daniel using inhaled tobramycin. He tolerated the therapy well, and so did Marianne, his mother. She developed a system for treating him, cleaning and disinfecting that worked for her, and after 28 days of treatment, a follow-up throat culture did not grow Pseudomonas for his medicine. However, his routine throat culture 6 months after that found that he was infected with Pseudomonas again. I've asked Marianne to bring Daniel back in today to discuss our options for next steps.
We did everything we were supposed to do, so why did the infection come back?
We're not entirely sure.
It could be that the eradication didn't work. We failed to clear the bacteria the first time because of resistance. Or it may be that the eradication did work, the Pseudomonas went away, and now he's infected with a new strain of Pseudomonas. So we have a few choices at this point. We could do another treatment with inhaled tobramycin alone. Or we could add a second antibiotic, oral antibiotic like ciprofloxacin, so you do tobramycin and ciprofloxacin. It's also possible that he's actually chronically infected with Pseudomonas. We should start chronic therapy, where we alternate an inhaled antibiotic every other month.
For how long?
If that's the case, it would be indefinite. It might be a lifelong therapy. I'm not quite ready to commit him to that, though. I think we should try eradication therapy again, but this time use a different antibiotic. There's another antibiotic we could use. It's called inhaled aztreonam. It takes about 2 or 3 minutes to administer, and it's done 3 times a day instead of twice a day, the way tobramycin is. And there's data showing that it's effective as well for eradication therapy. The side effects are similar to what you see with inhaled tobramycin. Things like coughing, sore throat, and occasional wheezing. There are some more rare side effects that we can talk about as well.
Is the same nebulizer used?
It uses a different nebulizer, especially made for aztreonam. It takes about 2 to 3 minutes to administer the medicine 3 times a day. And Sherry can show you how to use it.
Now this nebulizer is a little different. When you take the lid off, make sure you don't touch any parts inside the reservoir. It could clog up the head. The medication comes in 2 parts. The first part has the powdered medication down in the bottle. You'll have a metal tab. What you'll do is you'll need to pull the metal tab off and then take the rubber top off of it. Take one of the saline vials, squeeze all the saline down into the vial, put the lid back on, the cap back on, and gently swirl the medication. Once you see that all the powder is dissolved, then take the rubber cap off, open up the nebulizer lid, and pour the medication down in the reservoir. Once you get the medication down in the reservoir, make sure the cap is back on tight. After each treatment, you'll want to clean all the parts of the nebulizer with some warm water and some dishwashing soap. And then you want to disinfect all the parts. The best way to do that would be to boil them for 5 minutes with distilled water. And then once they're dry, then you can put them back in the container until the next use.
So are we in agreement that we should go forward with the aztreonam therapy for eradication?
I'd like some time to think about it and talk to my husband.
Sure, that'd be fine.
So a couple of things about that video. The first one is that he says that the little boy, Daniel, tolerated the medicine pretty well, and so did his mother. know, it's a lot of work. It's not only a time commitment, but it's a commitment to really being sold on this medicine is necessary. And then the other point that I wanted you guys to think about with that video is that there are a lot of unknowns. Whenever the Pseudomonas comes back, there's a lot of different options that we don't have as clear-cut of an answer as the initial question of should we treat it. Now there's many different ways to treat it, and it's just individualized for each patient. So let's see. Here are some risk factors of when the people who have Pseudomonas that reoccurs. So everybody with cystic fibrosis who has a degree of lung disease will have dehydrated airway surface and abnormal microclearance. But folks who have more chronic inflammation, remember that initial picture I showed you with a very red kind of bleeding airway? The more chronic inflammation there is and the more damage there is, the harder it is to get rid of microbes. So it's kind of a cycle. The more inflammation, the more likely you are to get infected, and it kind of goes in a cycle. So using the inhaled antibiotics tries to break that cycle. And then in one of the studies that they mentioned on here is folks who had difficulty with following infection control guidelines. For example, and this is, maybe stepping on toes here, but you guys have heard about the 6-foot rule. Well, some people don't take that seriously, and why not shake the hand of my friend who has cystic fibrosis because I've never met him in person? Those kinds of things. There's a reason for that, and in clinic we're extremely aware of how important it is to follow the infection control guidelines, and that's why we wear the yellow gowns. As you can see nationwide, they're always yellow. They haven't made any other colors. And wear gloves. And then also last year we talked about the infection control guidelines. I just want to remind you, whenever you arrive in clinic, it's important to wash your hands. Whenever you're leaving the clinic room, it's important to wash your hands. And I recommend when you get home, washing hands and maybe even changing the children's clothes if they've been rolling all over the clinic floor and that kind of thing. So, being aware of those, of the infection control guidelines is very important. So what is the optimal approach to administration of inhaled antibiotic therapy? This is a very real-life video of a young lady who is doing her inhaled tobramycin. She's sharing it with other folks, And so the point in this video is, sure, we can prescribe the inhaled medication, but how much of it is actually going to reach the lungs? And whenever we are talking to folks about what is the best approach to really trying to get rid of the Pseudomonas, we have to consider this kind of thing as the timing, how much time it takes, the commitment to a lot of other things, especially in teenagers who are extremely busy in high school, who are trying to participate in activities that they enjoy. And sometimes it is important to bypass the inhaled medication and do an oral medication instead. So each person is different, but this video brings up that good point. Whenever researchers are looking at making new medications, of considering how much of a burden is this going to be on each individual family. So other germs or microbes that can cause chronic infection in the airways are mentioned here. Burkholderia cepacia. Has anybody heard of that organism? Yeah. It's one of the most dangerous organisms, and right now the Cystic Fibrosis Foundation doesn't have an eradication protocol like they do for the Pseudomonas. there's not as clear-cut guidelines as there are for Pseudomonas. Non-tuberculous mycobacteria is a very difficult to treat organism. When somebody has non-tuberculous mycobacterium, it's a big overlap with their underlying CF lung disease, and on top of it, this other infection. And so a lot of times we will culture this, but we won't treat right away until we can prove that symptoms came from the non-tuberculous mycobacterium. And the treatment for it is about 3 months of IV antibiotics and then about a year's worth of oral antibiotics. So it's a very big commitment whenever we do decide that non-tuberculous mycobacterium is actually causing disease. And then MRSA. We believe that MRSA is one of the, similar to Pseudomonas, that it decreases lung function. Just because we see patients who have Bronet and then their lung function starts declining. But whenever they've actually looked at the Cystic Fibrosis Foundation reports that, you know, how everybody goes to clinic, gives us permission to include all their information into this big database. Whenever you look at that database, it doesn't seem that MRSA is causing the same degree of lung decline as Pseudomonas. However, it's still a very an organism that can cause a lot of inflammation, and so we're aggressive about treating it, but at this point we don't have the same protocol that we do for the Pseudomonas. So let me just show you this slide. You may have seen this before in other places. This is up until 2013. Again, taking the report from the cystic fibrosis database, where everybody's information goes into over years. This is 1988 all the way to 2013, the percent of patients who have all of these different bacteria. So you can see here, back in the 80s, Pseudomonas was the most prominent organism, and Staph was down here. And somewhere in the early 2000s, they crossed, and now Staph aureus is the most prominent organism, and Pseudomonas is the second most prominent organism. And we believe this is because of the eradication protocol that has been in place. This is a similar graph, but this one is looking at different age groups. So this is children less than 2, all the way to adults greater than 45 years old, and the percent of patients who have these different organisms. Whenever a child is first born, let me see, they tend to grow a large milieu of organisms instead of just one prominent organism. And you could read the names there at the bottom, but mostly it is Staph aureus, that's up here. And again, Pseudomonas tends to increase as the person gets older, and somewhere in the early 20s or mid-20s, Pseudomonas becomes a more prevalent organism in that age group rather than the Staph aureus. So it's still a problem for each individual, even though as a population, the amount of Pseudomonas seems to be decreasing, but for each person, it's still a problem that we have to address. So here's just a summary slide. Come on, summary slide. So people with cystic fibrosis have a higher risk of developing lung infections, and we went through the reasons why. An early diagnosis for that Pseudomonas infection is extremely important because of the long-term outcomes whenever you have chronic infection with Pseudomonas. And there's a lot of effective treatment strategies. So for one person, it might be different than for another person, but it's always a conversation to have with the cystic fibrosis provider group. And that's all that I have. Are there any questions around this topic, or just infections in general?
We talked about warm climates, wet climates being promoting growth
thanks for bringing that up. So, like I said earlier, Pseudomonas lives pretty much everywhere. Hot spots, and I guess they are warm spots, but are, like you were saying, in the shower, and enclosed hot tubs are extremely known for Pseudomonas, yeah. In fact, one of the very few things that, you know, we don't want children with cystic fibrosis to live in a bubble because they have to live life, but one very dangerous part for them is babies that are carried into the spa, you know, into the area where there's a hot tub, because Pseudomonas likes to live in those areas. As far as gardening and you know, working with the soil, that is more of an area of debate, because any dirt can have Pseudomonas in it. And if somebody really enjoys gardening, I think washing hands very, very well afterwards, making it a point of not touching your face when you're gardening, you know, those are things that we can work around with. And usually it's older folks who are doing the gardening, not the little babies, which you know, we don't want them to have a whole lifetime of Pseudomonas. So we want to take more precautions when they're younger. One thing that I don't have an answer to, and I tried to find an answer and I couldn't, is what about lakes? Pseudomonas, you know how we were talking, how it has a little tail and it moves? Whenever there is circulating water, it moves with it. But if it's stagnant water, that's when it's going to grow more. So kind of something to think about if the kids are going to go swimming in a lake is making sure that it's a lake that has circulating water, that is not just a stagnant water lake. But yeah, I remember a talk I heard by Lisa Green, which is probably a familiar name to you. She was showing us pictures of her two children growing up, and one of them was skiing. And she says she recalls the day when she found out that fake snow has so much Pseudomonas in it. And you know, she was feeling so guilty because she let her kids be exposed to all the Pseudomonas. But the more she talked to people and learned about it, she's like, it's everywhere. There was, you know, they had so much enjoyment. They're great skiers. It's one of their things they do as a family. And there's going to be Pseudomonas anywhere. So I think the key is to make sure that when we catch it, we try to treat it aggressively. Because like I said, the mall example, we, you know, randomly we're going to get Pseudomonas. So. No other questions? Sure.
This is actually a real timely topic for us because we just had a second Pseudomonas culture come back. So I was just wondering if there's any, if there's a delay between when you get infected with Pseudomonas and when you actually start the treatment with FKS or whatever drug was, you know, if there's a couple weeks, or is that, is there a window of opportunity that we're going to miss, or what we need to do again?
I don't think anyone knows the exact answer to that, but I don't think it's in the matter of weeks. Like the Pseudomonas is not going to convert into those little colonies in a matter of weeks. It's more in the matter of months and years. So from the point that you have the positive culture to the point where you start the antibiotic treatment, that's, I think, where there's no answer there. We try to start it as soon as possible. And somehow the Cystic Fibrosis Foundation recommends cultures every 3 months. So they must think that you know, living with it for 3 months is going to be okay. You know? So I wouldn't be worrying about delaying 2 weeks. Yeah. Although we want you to start it sooner the better.
I was going to wait another week.
Thank you.
Okay, so a couple reminders. We're going to have a panel discussion at the end. So if you have things you want to add, please write them on your note cards or text or email with the information on your table or email to kendra.darnell@providence.org. And then we are doing door prizes. If you didn't put your name in, you may want to run. But I'm going to do the first one so we can get going. And Oscar's going to come join us. We're going to talk about transitions and mental health. Always fun topics. Okay, so the first one is Randy Ammon. Did I say it right? I don't even know who that is. Okay, well, we'll hold it for Randy. Randy Hunt. I know who Randy Hunt is, though. The Randys are lucky. All right, and then it's just a heel in the bag and Subway. So we'll do one more right now. Seriously, Randy Palmer. That's and he's not here right now, but we will save him one. Anybody else need Randy? Because I'm just going to give you one. All right, we'll do one more. Jeff James. See, he asked a good question.
He just walked out.
Oh, then I was like,
But I'll take it more.
well, Sarah can come up on his behalf.
Don't let it go.
Old style. You don't have to tell him. We won't tell. Okay.
That was the Hawaii.
That's great.
Hello, good afternoon, everybody. My name's Oscar. I believe I've already met a lot of you guys. If I haven't, I'm excited to meet you guys at our next clinic visit. Now, this is my first education day, so I'm excited to see a lot of you guys out here. Hope you guys are collaborating and supporting one another. Now, before we begin talking about mental health, I wanted to show you guys a quick video about a patient who has CF. He's experienced depression, and so enjoy.
I remember being 9 years old and learning about life expectancy for cystic fibrosis. I was just pulling up an encyclopedia for a book report on Christopher Columbus, and I came to the term cystic fibrosis. Now I knew I had it, but I didn't know much about it. So I started reading, and that's where I learned that my life expectancy was only supposed to be 25 years. My reaction to it was I just didn't want to live anymore, and I freaked out, and I screamed to my parents, I blamed everybody that I could think of, and I ran to my room and just cried all night. My name is Andy Lippman. I am 41, soon to be 42 years old, and I was diagnosed with CF at birth. Cystic fibrosis is a disease that affects the lungs, the digestive system, and for me and most males, it affects the reproductive system. As far as describing my personality, I would say I'm a person who likes to take light of a lot of things. When you go to doctor's appointments and everything is so serious, you kind of want to take the edge off a little bit, so I tend to tell a lot of jokes, or I tend to try to be funny or make fun of things. I love to work hard, I love to work out, I love to constantly define what cystic fibrosis is to me. The biggest struggles I have, being that I have cystic fibrosis, it's not just the physical side, it's the emotional side. Dealing with the stress of having an infection, dealing with the stress of dealing with a life-shortening disease. When I was going through clinical depression, when I was initially diagnosed, one of the things I mentioned to the therapist, who said it was the exact definition, is I said I felt like I was in a well, and as I was climbing up, the well was getting deeper, and the hole was getting smaller, and I just couldn't get there. And I always thought, you know, this is a one-time thing, and it's over. It's like a cold. You get it, you get rid of it, it's gone. But I didn't realize it never really leaves. It's always there. It's kind of hibernating. Going to get help was a big thing for me, and it was something that really worked out for my family and for me. I've learned as I've gotten older that going to therapy, that dealing with depression and anxiety is a part of who I am, and it's a part of fighting this disease. If you can't do that, if you can't go to therapy, if you can't get better, if you can't work on the mental side of it, then it's hard, it's difficult to fight this disease every day. My joke is this: the only thing I ever hear positive about CF is the sweat test. And that's the only thing you ever hear about CF that's positive, and I'm sick of that. I want there to be a positive spin. I have a chance, because I'm different, I can use that to do great things in the world. There are 69,999 other people that have this disease worldwide, and I want to help them. I want to show them that we can live a longer life. The thing that keeps me fighting most, having cystic fibrosis, fighting most for my life, I used to say it was hitting goals, setting goals, reaching them, milestones, that kind of thing. But that changed when I had my children. When we had children, my goal was to live as long as I could for them. And yes, I use motivation as Andy wasn't supposed to live to see his teens. And when I hear that, or I think of that, I'm like, all right, I'll see what they can do now. I'm like, I think I may outlive some of my doctors. And that motivates the heck out of me. I'm kind of like, and I don't want to say I'm Rocky, but I use that movie as a big motivator, that a guy from nowhere, a guy who wasn't supposed to do much, can actually make a difference in the world.
So what a powerful story of someone who was depressed, and yet he's so successful now because he got treatment, right? He went to counseling, maybe some medications, but he had to go and get help. This year was my first time going to conference in October, and one of the main topics, if not the main topic, was mental health. So I was really excited because it was like my first 2 weeks, and I'm like, okay, cool, I'm ready to go into like Phoenix and learning about mental health and CF. If I just push right that. Okay. So the first premises of the plenary was that our well-being includes both the physical and mental health aspect. Now we're doing everything we can physically to improve our health, right? We're exercising, we're taking our medications, we're on doctor visits, but one of the things that's not really talked about is mental health. But in order to have a holistic approach, we have to have mental health talked about. And that's exactly what Andy did throughout the video. He sought help. So in order to achieve a well-being, we have to get mental health. The second premises of the plenary was that we have reliable and valid tools to measure these symptoms. Starting this year in January, we started screening for depression and anxiety using two screening tools, the PHQ-9 and the GAD-7. PHQ-9, it's a simple test, 10-item questionnaire, and what it is screens for depression. The second one is the GAD, and that screens for anxiety, and it's also a 10-item questionnaire. So we do have those valid tools that we're currently implementing. If I haven't screened your family members yet, it is to come, promise. The third premise is that if we have a chronic illness, or if you care for a child with chronic illness, it's normal, right? Depression is normal. We all get depressed. There's breakups, there's finances, child custody issues. I mean, depression is just everywhere. Turn on the news, there's a bunch of negative things on there. It happens. But the good news is that we're screening, we're seeking help. Now, going back to the physical aspect, if there's an obstruction in our lungs, there's an infection and causes inflammation. Now, in the mental aspect, if you guys can imagine, if there's an obstruction, say a breakup, we get depressed. And with that obstruction, it causes a next phase into it, right? We get depressed, we start having symptoms, and that can get worse and worse. Mild depression becomes moderate depression, now becomes major depressive disorder. And so it gets worse and worse if it's not treated. Same thing physically. If something's not treated, it can get worse and worse. So I think it's really important to know that we need to prevent it from getting worse and worse. Same thing, basically what we just talked about, it prevents certain things from happening. Adherence is a big one. We'll talk about that here in a minute. So research has actually shown that if we do have mental health issues, right, depression, there's actually more missed clinic visits, more exacerbations, lower BMI, and overall our quality of life is not the best it can be, right? We want to stay at home, We don't want to do a whole lot of things because it's real. Depression is real. Now, thousands of people, if not millions of people across the nation and the world are currently experiencing depression, insomuch that the CF Foundation conducted a study entitled TIDES, stands for the International Depression and Anxiety Epidemiological Study. And what this study did was it surveyed around, I think, 6,180 patients. I'm going to say that on the next slide. But this was nationwide, so in the U.S., and it was in 8 European countries. And they screened for both depression and anxiety. And so in total, it was about 10,000 patients and caregivers who were screened. And what they found was, overall, that about 2/3 of patients are currently experiencing depression. You know, because finances, hospitalizations, I mean, you name it. They're really going through a lot. Same thing with anxiety. Now, this is above the clinical cutoff score. So these patients or the community is already clinically depressed. Now, patients with CF are actually 2 to 3 times more higher to have depression and anxiety. And that's above the clinical score. Does that make sense? So they're like a lot more because of everything that's going on with finances, physically, I mean, all the other stuff that's going on inside. So the same thing shows with anxiety, 2 to 3 times more likely above the clinical cutoff score. In essence, this research shows that there's a high prevalence of depression with anxiety in people with CF and caregivers. And this affects, like I said, adherence, healthcare costs, and the quality of life. Parents are also reported to have a high prevalence of depression and anxiety. It kind of correlates. If your parent has depression, or if your mom and dad have depression, you're more likely, I believe it's about 4.8 times more likely that your son or patient is going to have depression himself. So that's why it's important. And I know it says thank you, but I'm not done yet. So as you guys can see, 48 times more likely to be above the clinical for depression. So this is why it's important for us to start screening our patients. And I know it's more paperwork every time you guys come into our clinics, but it's really important. I myself have seen family members who are really affected by depression, and there's only so much a family member can do. And how I wish someone else would have stepped in and helped me out through my family situation. I mean, it would have made a world of a difference. And so that's why I'm here trying to screen patients, because I saw what it did to my family. And I can't even imagine what's doing your guys' family, right? And from what I've seen is that we don't like talking about depression. We don't like talking about what's going on to our family members. For instance, I don't want to tell my brother about what's going on, or my aunt about what's going on, you know, because I don't want to stress them out. And so sometimes it helps a person like our care team to step in and say, hey, what's going on? You know, we screen them, and I'll talk about our screening process here in a minute. But it opens up doors of conversation to figure out what we can do, you know, clinical help. So going into our clinic, our secretaries are great at handing out the PHQ-9 and GAD, the 10 question items. And so you guys will fill that out, and then the results will get brought back to me, and I review the results. And if it comes out positive or negative, I go back and talk to the patient. And the ones that I really look for are the more severe items, so the 2s and the 3s. And you guys will see that once you guys come to our clinic. So the annual screening is done once a year. And if it's mild or normal, we do supportive interventions, kind of, you know, try to seek counseling. If not, then we'll rescreen on our next visit, because it's not moderate or severe. We really want to get the moderate and severe patients into counseling and psychiatry. And you guys will see that here. But patients that we're going to be screening are patients who are 12 years through 12 and above, I'm sorry. And if they're younger than 12, and if you guys feel the need to have them screened, please let us know, we'll screen them. So in summary, people with CF and their families are at high risk for depression and anxiety, leading to both poor quality of life and poor health outcomes. And so an international working group has created the consensus of mental health screening and treatment guidelines for people with CF and their caregivers. So what we're going to start doing, like I said, is we're already doing it, is screening our patients, getting them out to counseling, and seeking medications. And if you guys ever feel like you guys are going through depression or anything's going on, please let me know. I mean, I'm here to help. And sometimes it may take a while for me to get back to you guys, but that's because there's such a huge need of getting counseling and limited resources. And there's only so much one person can do, but I assure you, I'm going to try my best to make sure that there's counseling sought after and we're seeking the right medications. Because what we want is that holistic approach, not only physically but mentally, because we want to provide a holistic point for us to live the best quality of life that we can. So thank you guys for that. So that's pretty much what's
And I want to point out, I thought the numbers, if you saw for mothers, was incredibly high. And so, we live in a super mom era. All of us want to be the best moms we can. I think moms take a brunt, not the dads. I mean, we love the dads. Thank you for being dads. But I think moms take a lot on. And so, the screening of parents is really because the studies support it. And so, sometimes it's not going to always be medicine. It won't always be a certain kind of counseling. Like Oscar was saying, sometimes it's supportive. Maybe it's some mindful meditation. But I think what we do know is a stressed out mom or a depressed mom will have poor health outcomes in the long run. So this is not just about, this is really about still your child's health. I mean, really, it still is. And so don't be surprised when we're saying, no, you fill this out, not for your child. And that's new, that's new for us too, because you're not our patient. But Oscar's working at a way to deal with that and still provide you with the privacy. And if you need to talk away from your child, or if you want to have that, talk at a different time when your kids are in school and you want to have a little time to talk, know that that's available.